This is vestibular diagnosis. My name is مراد. I am professor of otorhinolaryngology. This is part of your schedule as the fourth year students. I would like to first introduce the intended learning outcome of this lecture. First is to learn the anatomy of the vestibular system. And second is to understand how the sense organs are arranged and related to each other between the ears. Third is to understand the head movements, which are the trigger for stimulating the vestibular sense organs. The head movements are movements that have, they change their, where they move in different planes of space. Number 4, I want you to correlate the Number 4, I want you to correlate the plane of head movements of the head to the correspondent sensory organ arrangement and response. So, then we need to develop a systematic approach to evaluate the vestibular diseases. In this sense, I want you to know that we should learn the importance of history taking in our systematic approach to evaluate vestibular diseases. History taking includes also guided questions. And I want you to know how do we go about to test the vestibular apparatus through bedside procedures. And finally, to develop a simple approach to localize where is the site of pathology of the vestibular lesion. Now, I want you to look at the anatomy of the ear. Here, where we are looking at the external auditory, the pinna, the external auditory canal, the middle ear, and finally this blue apparatus, which is called the labyrinth, and it consists of the cochlear part, and this is like a shell, 2.5 turns, and the vestibular part, which are 3 semicircular canals and 2 patches of utricular sensory organs. This is the part which we are so much concerned in, is the inner ear or the labyrinth, and here is the 3 semicircular canals. As you see, one is vertical and the other is vertical and one is horizontal. So we have 2 semicircular canals are present in the vertical planes, and 1 semicircular canal is present in the horizontal plane. And we have 2 patches here. It's just a patch and another patch. This is present in the vestibule and is called the utricle, and this is present in the saccule and is called the saccular macula. The 5 parts that we are looking at are very important in sensing the head motion, whether in the vertical direction, in the horizontal direction, or in the sense and in relation to the gravity. A reminder, now we want to see, does the right side or the right labyrinth relate to the left labyrinth in its presence in the skull? Yes. First of all, the labyrinth is present in the temporal part, the petrous part of the temporal bone. And there are always 2 canals that are related to each other, or on one side there is a kind of relation to the other side. So if we look at the semicircular canals, their orientation are such that one canal, for example, this is the anterior vertical semicircular canal, is so much correlated and is in the same parallel plane as the posterior semicircular canal on the other side, such that when the head moves forwards or backwards in an angular manner, then one canal will be stimulated and the other canal will be inhibited. This is very important, such that we have a push or stimulation, increase in the firing rate, and a decrease in the firing rate. Similarly, we have this in the horizontal canal. If you turn your head to the right side, your right semicircular canal horizontal will be stimulated, and your left semicircular canal in the horizontal plane will be inhibited. So these are coplanar from the same plane pairs that sense head motion in any direction of space. And similarly is the patches of the utricle and the saccule, the maculae of the utricle and the saccule. They are also working in harmony, so that change in one direction, like a tilt reaction, or when there is a gravity pull on the head, one will be stimulated and the other will be inhibited. However, in the resting head position with no motion, both labyrinths or both components, all components of the vestibular system are having a resting firing rate that is equal on both sides and for each canal. Once we know now what are we dealing with in terms of the vestibular apparatus, we want to go into vestibular disease diagnosis. The first thing that we want to look at is the history taking. And by history, we want to have three main components. It is the complaint of the patient. He comes as telling you what is his experience, why is he coming, because what is his feeling. And the second is what are the things that happened around the complaint, which we call the present history, and what is his past medical history in terms of any disease, trauma, medication, and so forth. And then we want to know some guided questions. You are saying these questions during the history taking. What are these questions? Number one is, what is the character of dizziness or vertigo as experienced by the patient? So you ask the patient, tell me, how do you feel it? What happened in terms of, is your head spinning? Or is there any loss of balance? Or is it blurring of vision? Or illusion of space spilling, or a sense of syncope, or did you experience a fall? The second guided question is, what is the duration of this experienced dizziness or vertigo? And what about its onset, its duration? Is it short? And this means seconds to minutes, long, hours or days? Is it recurrent attacks, or it is constant, like a chronic condition? And what is the effect of head position? And this is very important. Third guided question is, what are other symptoms associating vertigo? Because vertigo or sense of spinning or sense of fall or dizziness may come from different sensory receptors and sensory organs. It may come from the brain, it may come from the ears, it may come from proprioceptive sensations. So where we have to look at other accompanying symptoms. These are either ear symptoms like hearing loss, tinnitus, ear pressure, earache, or ear discharge, etc. So if it's accompanying with ear symptoms, the problem maybe is related to the ear. However, if the patient experiences other neurological problems or neurological symptoms such as migraine or headache or epilepsy or diplopia or tremors, then we have to think that the symptom may be originated from a neurological substrate. Now, if it's psychiatric symptoms like anxiety and depression, usually dizziness or vertigo may associate these patients, and we have to put in consideration that there may be a psychiatric problem. Cardiac symptoms, yes, arrhythmia is disturbance of the pulse rate, and this will eventually mean there is a disturbance of the blood flow and may lead to syncope, and these are very important and are emergency problems. So these symptoms should be considered in terms of the dizziness or the vertigo experienced for the appropriate intervention. Medication, some people were taking medication in the prior onset of the symptoms, and if you read the pamphlet, you might find side effects for this medication. They may be experiencing some kinds of these side effects, or there is a history of ototoxic medications like gentamicin or aminoglycosides. They may be taking chemotherapeutic agents and so forth. Now we took the history and we know what is the anatomy of the vestibular apparatus. Why are we seeing, how is the vestibular apparatus connected such that it gives us these symptoms? First of all, the vestibular apparatus is linked through to the eye through what we call a vestibulo-ocular reflex, and this the main function is to keep the eyes or the gaze in a stable position, and this very much helps you to keep your body equilibrium and balance. The second reflex is the vestibulospinal reflex, and this again helps you straighten or help get all the muscles of the trunk and the body in relation to the movements to the ground or to the gravity and so forth. So for the first reflex, to keep the eye stable on a visual field, we have what we call the vestibulo-ocular reflex. Any reflex arc is composed of 5 components. The first is the sensory, the second is the afferent, the third is the center, and then the fourth is the efferent nerves, and finally the effector muscle. So in this context, we have head motion or head movement in an angular fashion. So it's like moving like a ball in an angular fashion. If it moves into a horizontal direction, you are mainly stimulating the horizontal semicircular canals. If the head is moving in a vertical direction, it is stimulating the vertical canals. And from this kind of stimulation, the sensory receptors are stimulated, and the firing is increased and goes through the afferent, which is the vestibular nerve in this portion, and relays into the vestibular nucleus in the brainstem, and from there is an interneuron connecting the motor neurons of the oculomotor nuclei, and finally we have the efferent through the efferent nerve supply to the particular muscles that will move the eyes to stabilize the vision. If you move your head in a horizontal direction, the eyes will move in a horizontal direction but in an opposite direction to the head motion. So if you're moving your head to the right, your eyes reflexly will move to the left, and in this motion the eyes will keep the gaze or the visual field stable while your head is moving every little second. If you move your head in a vertical direction, what will be stimulated is the superior rectus with the inferior oblique, and again the inferior rectus with the superior oblique, so that the eyes will move up and down according to the movement of the head, an opposite direction, equal and opposite direction to the movement of the head. Why? To keep gaze steady and not you lose your visual field or your visual surround during head motion. The vestibulo-ocular reflex starts at the vestibular sensory receptors and are triggered by fast head rotation or angular acceleration. What is stimulated? As you can see, these are the three semicircular canals. Each one opens in the vestibule with an ampulla or a ballooning of the end of the semicircular canal. This is the part, this is a ballooned, and this is the ballooned, and this is the ballooned part. Why is it ballooned? Because in each balloon there occurs a sensory organ complex. What is this complex? It is the sensory receptors that has the hair cells on top of it, and all are immersed into a gelatinous part. It's like a bridging from the base up to the wall of the semicircular canal, the membranous wall of the semicircular canal. All this is surrounded by the endolymph or the fluid inside the membranous labyrinth. Now, when the head moves, what will move with the head is the bony part of the labyrinth and the membranous part of the labyrinth. But what will lag behind is the fluid, which is not attached to the walls of the bony and membranous labyrinth. The movement or the lag of the fluid, the endolymph, will make a change on the pressure of the copula, which is the gelatinous part that is circumscribing all the hairs of the sensory receptors. What happens is that as the endolymph moves or lags, the copula, the gelatinous copula, is displaced from its original or resting position, and it drags with it the stereocilia that are embedded into this gelatinous part. Now, the movement of the stereocilia towards the longest kinocilium, or the tallest hair cell, will eventually make an increase in the firing rate in the vestibular nerve. Now, but motion in the other direction will make a decrease in the firing rate, and this happens in the two coplanar semicircular canals, or the semicircular canals that are placed in parallel planes between the right and the left ears. So in one, the endolymph will cause stimulation or increase in the firing rate, and in the other there will be a decrease or inhibition of the firing rate, so that the head, when it gears to the right, there is stimulation of the eyes to move to the left. So what about now the vestibulospinal reflex? This is a photo, an organized photo that shows you how the vestibulospinal reflex is triggered by linear head acceleration. And when we talk about linear head acceleration, it means that the pull of gravity is linear head acceleration, causes a linear head acceleration on the head. If you are up or down the elevator, you are against gravity, and there is a change in the linear head acceleration. If you move your head in a forward direction or a backward direction, this is again head acceleration. If you tilt your head only, this is head acceleration towards the gravity. And therefore, we have a stimulus that is the gravity linear acceleration, or a motion in a straight line, not an angular acceleration. It stimulates different sensory organs in the vestibular apparatus. The sensory organs are the macula of the utricle and the saccule. So the sensory receptors again are the vestibular hair sensory cells, and these are the sensory receptors, but they are not placed in a ballooned area. They are placed in a patch in the vestibule called the utricular patch, or in the saccule called the saccular patch. or the secular macula. Again, as the construction in the copula, we have the same structure in the macula of the utricle and the saccule. There's the sensory receptors, and these are the hair cells, and as you can see, there is an arrangement where we have a tallest one called the kinocilium, and all are immersed into a blanket of gelatinous material covering all the patch. Because this gelatinous material does not have a significant weight, it does have minimal weight, so that the pull of gravity is not effective. Therefore, there is present on this a blanket of otoconia or sand particles, the same composition as sand, and filling a blanket covering all this kind of gelatinous membrane, or that is in which is immersed the hair cells, the stereocilia. Now, if you tilt your head, then the gravity will drag or pull on this membrane, and when this membrane is pulled, they will drag the stereocilia and the kinocilium. Motion towards the kinocilium will make an increase in the firing rate. Motion away from the kinocilium will decrease the firing rate. Now, increase or decrease of the firing rate will be sensed by will convey its pulses to the efferent, which is the vestibular nerve. And again, the vestibular nerve will go into the center in the brainstem, the vestibular nerve, the vestibular nuclei. From the vestibular nuclei, we have a very long pathway, the vestibulospinal pathway, that will go all the spinal tract, and in each vertebrae there will be an outlet, which is the efferent spinal nerve. It will relay on each anterior horn cell, and there is an efferent, which is the spinal nerve. Now, what is the effector? Are the neck and body muscles. All are being stimulated. Some are stimulated, some are inhibited according to the tilt of the head and the relationship between the right and left utricular and secular macula. So again, a reflex starts by a gravity change in the gravity linear acceleration will change all the contraction and relaxation of your body and neck muscles, such that you don't experience a fall while your head is tilting, or while you are standing in pray, or standing up, or so. Now we know that we have a symptom, which is vertigo or dizziness, and we have analyzed the symptom, and we have known what are the sensory receptors and what governs their action as a reflex, and now we want to go into the physical examination. So first of all, we want to do a standard ENT examination, a basic audiologic evaluation to know whether you have a problem in the hearing apparatus or not, the cochlea. Examine the vestibulo-ocular reflex for the presence of what we call nystagmus, and examine the vestibulospinal reflex by testing the balance and gait, the posture, the coordination, and fine motor skill. If we start by the vestibulospinal reflex testing, we want to know, when you see the patient coming in, and what you see is his balance, his upright balance, his gait, his equilibrium, his posture, is it upright or is he supported by other people, his coordination in terms of what are the cerebellar input, is it okay or not, and this, if you coordinate between head and finger nose test, or the fine motor skills, these are the cerebellar actions that we want to circumscribe and know how they influence the balance and gait and posture. If we examine for nystagmus, we are examining the vestibulo-ocular reflex. The patient may come presenting with this kind of motion of the eye, either in an involuntary position status or induced by an examiner to see this kind of eye movement. So to define nystagmus, it is rhythmic. As you can see, it is a repetitive motion of the eye, involuntary, and it is an oscillation of the eyes. It has a slow component and a fast component, so that the eyes will do, this is the fast, and then it goes slowly to the other side, fast, and goes slowly to the other side. How to examine for nystagmus? You want to observe as logic for eye movements. When and where you want to examine this in darkness, because in darkness you can see very well the eye movements and you can record it, and you can only observe it and also you can record it. What we use at the bedside is what we call Frenzel's glass. These are 20 diopter lenses, so that they function as they prohibit the patient from fixating and at the same time serve as a magnifier lens for the examiner to see the eyes in a magnification status. And you want to observe for eye movements with the eyes open. When the eyes open, you put a little bit of light and you see if the nystagmus that you are seeing with Frenzel's glasses in the darkness is suppressed or goes away or declines or fatigues when you put light. This is called suppression of nystagmus. So, vestibular nystagmus may be spontaneous or induced. Spontaneous, it means that the patient comes, you look at his eyes, and the eyes are moving back and forth in a repetitive manner without you doing any manipulation to the patient. Induced, that you manipulate the patient to induce nystagmus and see it if it is present. And vestibular nystagmus does not only relate to the labyrinth, it is where we call it peripheral, it also has a central origin where we call it central or vestibular nucleus affection. Here is spontaneous nystagmus. It may occur from a peripheral lesion. You see the eyes again having a fast and a slow component. What causes this situation? This situation is caused when we have one labyrinth versus the other labyrinth. There is asymmetry in the resting discharge. So in normal, the right labyrinth and the left labyrinth will have equal symmetric resting discharge. So no VOR or vestibulo-ocular reflex is created. The eyes are quiet and no motion of the eyes. But when disease affects one labyrinth and leaves the other okay, then here the resting discharge drops, while here the resting discharge remains as is. What is the interpretation of this? Is that we have this means as if the head is moving towards in the direction of the healthy labyrinth, and the VOR will move the eyes towards the affected labyrinth. And then the eyes, when they go in a slow fashion in this direction, they come back by their elastic recoil to their center position again, and this is the fast phase. However, the pathology is still continuing. We have firing and no firing, so asymmetry in the discharge. Again, the eyes will go into the direction of the affected side slowly and then return by their elastic component to the center. As the pathology is present all the time, during the presence of the pathology, which may be transient, taking a few hours or a few minutes or a few days, there is always, you can see this nystagmus. nystagmus. When the pathology stops, like in fluctuant ear diseases, like Meniere's disease, you are having an abrupt onset of nystagmus that lasts the duration of the pathology and then declines as the pathology goes away. This happens again also in acute labyrinthitis, inflammation of the labyrinth, vestibular neuronitis, where you have at the Scarpa's ganglion an inflammatory process because of a virus and making it suppress its discharge, and in Meniere's disease, which occurs in a fluctuant and a transient timing. What is the character of a peripheral lesion? It is usually unilateral. It is suppressed by visual fixation, and it is associated with other ear symptoms like hearing loss, temporary hearing loss, or tinnitus, or ear ache, and so forth. Suppressed by visual fixation because there are two forces governing the eye stability. One of them is the vestibular apparatus and the other is the visual apparatus. The visual apparatus is more dominant than the vestibular apparatus. So if you make this patient look at a light, fix on light, this nystagmus will decline to 0 as by visual fixation. And this helps you say that or suggest that the lesion is only in the peripheral ear and not in the center of the brain, in the pons. However, if you see spontaneous nystagmus that is suspicious of central origin, it has the same character. A component that is fast and a component that is slow. But it can be vertical, it can be upbeat or a downbeat. This is a horizontal beat, okay? And if it's upbeat alone or a downbeat alone, this is suspicious of a central component. And what you have at the bedside, what you can see is when you see a horizontal nystagmus or a rotatory nystagmus, because all the semicircular canals are involved, what you can do is ask the patient to fix on light, and this nystagmus, if it's suppressed, it will be peripheral. If it's not suppressed and continues to behave as is, then the visual dominance is not present, because in this area we have pathways for the vestibular and for the visual and for the proprioceptive. And because this is like the neck of a bottle, it is a very narrow space, so affection of one pathway may also another pathway may also be affected as well, and so both the vestibular and the visual may be assumed to be affected, and therefore the visual that is dominant will not suppress the nystagmus coming from the vestibular, and there will be associated neurologic symptoms. Induced nystagmus. This is nystagmus induced by position change, either peripheral or central. Nystagmus or nystagmus induced by caloric stimulation. Positional nystagmus, it is normally not present. It is induced by position, and the maneuver that you do is called the Hall-Pike maneuver, named after a person. It's called Dick's Hall-Pike. And it is maybe peripheral or central, and it has a characteristic or a pattern. It is latent to onset, and once it comes in, it is fatigable, and we say it is paroxysmal. So if we have positional nystagmus, we don't see it while the patient is sitting. So if you want to induce it, you get the patient in the sitting position, turn his head 45 degrees to one side, and push him down to hang his head while hoarding on the edge of the bed. Now, You wait a few seconds, and if you see a burst of rotational nystagmus or torsional nystagmus, that fades in a few seconds, this is what we call positional nystagmus, and in this particular type we talk about benign paroxysmal positional vertigo. What is happening here is some of the otoconia or sand particles that has been covering the macula of the utricle crack and down and float in the endolymph and go to the posterior semicircular canal, which is the most dependent part towards gravity. This otoconia will not only float but will push the copula. When you put this person in this direction, it will push the otoconia, be pushed by the otoconia, signaling an increase in the firing rate and seeing this kind of nystagmus. And once it is pushed, it will not do this again, and therefore you get a fatigue for this nystagmus. As you can see, the patient sits and then you bring him down to this position to see the nystagmus. If it occurs, then this is benign paroxysmal positional vertigo. If it does not occur, you don't have any positional nystagmus. These are the otoconia that you can see. This is the patch of this is the utricle, and this is the saccule. Some of the otoconia get cracked and they fall down. Either they fall and stick to the copula or be around the copula. When the head moves, there is a push on the copula, creating the vestibulo-ocular reflex in a fashion that it goes into a burst. These are the otoconia that may be present in the semicircular canal and coming from the utricle part. What about caloric testing? This is another test that can test the integrity of the vestibulo-ocular reflex. What do we mean by that? If you have the temperature here of the person is about 36 to 37 degrees, and you put warm water or cold water into the external auditory canal, it will go and warm or make the tympanic membrane and the middle ear cooler. If you know what we mean by convection currents, is that when you have a pot on fire, you have the lowest part near the fire, the water for example, will heat and will go and circulate upwards, and then the cooler water will go downwards, giving a current in the water. And this is the same. So if we have a current occurring in the semicircular canal, and in particular in the lateral horizontal semicircular canal, we will get the endolymph moving, and when it moves the copula. If we use warm water, it will move the copula towards the vestibule, and this will create what? It will create a stimulation, and we will have the vestibulo-ocular reflex. If you use cold water, there will be motion of the endolymph away from the vestibule and will create an inhibition of the vestibular apparatus, and again we will have depression of the firing, and the eyes will move in the other direction. As you can see, this is the nystagmus occurring, and this is the slow phase, and this is the fast phase occurring as long as we are irrigating the ear and getting the water back in a basin. You can know the strength of this vestibular nystagmus by calculating the slow or the fast phase velocity and putting it together to know which ear is the weaker. Are they both equal and okay, or one is weaker than the other? So you can go now and classify where is the lesion for the vestibular insult. It may be within the labyrinth, vestibular labyrinth, like what? Hydrops or Meniere's disease. It may be an inflammatory, like in labyrinthitis, whether viral or bacterial. It may be degenerative, like the degenerating otoconia. It may be ototoxicity affecting the cells or the sensory receptors and the stereocilia of the sensory receptor. All this will cause to us nystagmus. You can separate them by history taking, because once you can test and see the nystagmus, but from the history you will know whether there was an inflammatory process, a degenerative process, an ototoxic process taking place, history and associated symptoms from the other organs, or from the ear or from the brain also. If you look at the vestibular nerve may be insulted, and if the vestibular nerve has experienced an insult or a pathology due to infection or to a surgical trauma or to a tumor like the vestibular schwannoma, then you can see again a number of nystagmus, and you can see dizziness or vertigo or instability, and you can resolve this again from the history, from of surgical trauma, from tumors by MRI. So you can know about the vestibular nerve and localize the lesion to be within the vestibular nerve. It may be in the brainstem, and this may be affecting the pathways in the brainstem, demyelinating diseases, again degenerative diseases, and vestibular migraine, an entity that is coming up strongly in the literature and in clinical practice and has guidelines, so that when there is a vestibular symptoms associating or coming after or before the onset of headache, throbbing headache, severe, moderate to severe headache, and being repeated during each month, this is vestibular migraine. Thank you.